within the next 6 months to a year, we're hoping to create this pleural program now with the 2 new interventionalists that have joined. We'll have more time and dedicated time for this. And of course, there will be more time for teaching to you guys, so you guys can handle the chest tubes in the hospital, which is the way it's supposed to be, or at least know more about how to handle them. Thanks to Mohammed that actually helped with all this part in terms of putting everything together too. And thanks to all of you for coming. So to remind you, today is the theory part for everybody. There will be a hands-on part that will happen this Friday, meaning tomorrow, and next Friday on the 20th. It's going to happen at 2 p.m. in the anatomy lab. Okay, the anatomy lab is at the basement, right? You take the main elevators to the basement, make a right turn, and ride the first corridor there at the anatomy lab. So the first group, which I think is the second year first, right? So kind of like mixed. Will be there tomorrow. Okay, expect to be there from 2 o'clock to approximately 5, maybe 5:30. And the second group will be the next Friday. Okay, there will be time for everybody to work on the cadavers. So we made arrangements for cadavers to do this. We made arrangements with companies also to provide with the chest tubes and then well and pleural catheters. So it has taken a huge effort to do this, so please do not, please attend and be on time, okay? So I asked you to watch a video before this. It's just to have an idea of how a chest drainage system works. You probably are kind of familiar, but not that familiar. And I actually thought that Dr. Ouellette's video was actually great in terms of explaining this. So you kind of have an idea now. So we're going to start.
Go ahead, I already started recording, so you can flip through the slides if you want to.
Okay. So, first we're going to talk about chest tubes, and then we'll go to indwelling pleural catheters. You probably know them as Pleurex catheter. Pleurex is just the brand. There are other brands on the market, although Pleurex is the oldest one so far. So, let's go over. Here we're going to talk about more practical stuff. We're not talking about studies and going over, which one works or not. This is kind of the preparation for your hands-on workshop for tomorrow and the next Friday. So what are the indications for a chest tube? We all know. So number 1, pneumothorax, right? Now, this is kind of a, you want to dim the lights a little bit so you can see better. So pneumothorax. Every pneumothorax needs a chest tube? The answer is no. So there are actually criteria that actually go with pneumothorax. And then you'll find them in, actually the most recent one, and the one that we tend to use most of the time is the one from chest. Actually, it's kind of old already. It's old. Or a... can you guys see well? I feel that it's not. Okay, that's better. So pneumothorax, the guidelines for the criteria for placement of pneumothorax, of chest tube in the pneumothorax, pretty much is variable at this point. Okay, we don't have really good criteria. We follow the criteria done by ACCP 8 years ago, or by the British done 10 years ago. Pretty much, if the patient is symptomatic, you place a chest tube from the pneumothorax, right? If the patient is hemodynamically stable, you place a chest tube. If the pneumothorax is more than 1/3, you have to assess. You either place it or not place it. There's a lot of discordance there so far. So, but just to have in mind, if you have a patient with a pneumothorax, not every pneumothorax needs a chest tube. Hemothorax, very important. And we're talking about the frank hemothorax. We're not talking about the bloody fluid that we find sometimes in patients with cancer or any kind of trauma there. You're talking about the real hemothorax. The real hemothorax, frank blood coming out from the pleural space. They do need a chest tube. Otherwise, they will cause and they will create a lot of scar tissue, fibrotic tissue in there that will actually end up with a trapped lung in the future, in the near future. Pleural effusions. We place chest tubes for pleural effusions, either to accelerate the drainage. Number two, to evaluate and assess whether there is re-expansion of the lung or not. Whether remember, if the pleural effusion has been there for a long time, in the case of malignant effusion, for example, or any trauma in the past, patients do develop trapped lung. So you want to know whether this effusion is associated with a trapped lung or not. And the way to do that is putting a chest tube, draining it, tap it dry, I would say, and then you actually are going to be able to evaluate and assess the function of the lung at that moment. You use it for effusions. We're talking about malignant or pneumonic effusions. Empyema, and empyema, what it is a complicated pneumonic effusion that actually with frank pus. That's what empyema is. It's not necessarily just a complicated pneumonic effusion that looks like a normal effusion, normal fluid that grows some bacteria. That's not an empyema. That's called a complicated pneumonic effusion. Empyema is pus coming out from the pleural space. In those cases, you do need a chest tube. Pleurodesis. We use chest tubes also for to do pleurodesis, to perform pleurodesis through a chest tube. It's actually well known already in patients who have recurrent or recurrency of the effusion, right? So you need to have a recurrent effusion for a reason. After you find out what the reason it is, then you can actually access and do a pleurodesis. Now, what are the contraindications? The absolute contraindication for a chest tube is if the patient needs an emergent thoracotomy. A patient usually with a trauma, they present to the emergency. You know that the patient is bleeding inside. You know that the patient will have to go for a thoracotomy immediately. Do not place a chest tube. Talk to the chest surgeon first, to a thoracic surgeon, and come up with a plan. Do not place a chest tube in those cases. Absolute contraindication. Relative contraindications. If the patient is anticoagulation, or has any sort of coagulopathy or bleeding diathesis, it could be a relative contraindication. There are now more studies showing that putting a small bore chest tube in patients like this, who are actually even on complete health, Plavix, actually could be safe. Of course, these are all retrospective, but there's some data out there that actually may show that it's not unsafe at all. In general terms, if you are not proficient with a chest tube placement, don't do it in this kind of patients. You need to have a lot of experience in order to do this. A transudated pleural effusion. Well, it's also in discussion, right? You know that a patient has heart failure. You know that you have to diurese the patient. How is that going to help to put a chest tube? We're not talking about thoracentesis. That's different. I mean, you can do a thoracentesis and drain fluid. You know it's going to come back, right? So how is that going to help you? Really, a chest tube, you're going to have to keep the chest tube forever. Just doesn't make sense. So you need a medical management. Yes, there are some studies, and you probably know about that in the ICU a few years ago, showing that drainage in this kind of patients with a chest tube, at least to extubate the patient, will accelerate the extubation of patients, and diminish the ICU stay. So it can happen, but as I said, not as a permanent treatment. Blind insertion. If you don't know what you're going into, if you don't know the anatomy, don't even place a chest tube. Okay? That's very important. So that's a relative contraindication too. Unless the patient has developed a pneumothorax or intention pneumothorax, in that case you need to do decompression. That probably will be the only reason. But if not, don't do it. You need guidance. You need somebody that stays with you during the procedure. You need to know where you're going. What is the position for a chest tube insertion? Different positions have been actually given. The classic position. Patient is in supine, 45-degree angle, usually. The arm of the affected side, meaning the arm on the side where you're going to place the chest tube, is actually extended, rotated, like behind your head, behind the head of the patient, ideally. Or if you're placing a pneumothorax, or the reason for the chest tube is a pneumothorax, you don't need to do all that. The arms can actually be straight, because most of the time you tend to go anteriorly on the chest. Okay, so that's important to know. Now with the era of ultrasound, you can actually find a place where most of the fluid is, if this is because of an effusion, and then you can position the patient as you wish. Okay? The site. Where do you place a chest tube? In which part of the body? So, if you're thinking a pneumothorax, if you have a patient with a pneumothorax, you want to place a chest tube. So, there are two places, or two areas where you actually can go. You can go in the 4th and 5th intercostal space, and as I said, this is probably more guided for thoracostomy tubes. Okay, the thoracostomy tubes, called surgical thoracostomy tubes, are the ones that are placed by surgeons. Usually, you make an incision, you dissect all the muscles, get into the pleural space, and then advance the chest tube. That's not what we're talking about right now here, in general. But this is actually, these places to place a chest tube on the body were actually made out of that. So 4th and 5th intercostal space with the anterior or the mid-axillary line for pneumothorax. Always try to direct it anteriorly if possible. Or you can go into the 2nd intercostal space and in mid-clavicular line, because it's harder to see pneumothorax with an ultrasound. Sometimes, I mean, you need a lot of skills to do that. It is good, actually, that you find at least the pleural line with the ultrasound to make sure and to confirm that you're placing the tube in a patient with a pneumothorax. Now, if you talk about pleural effusion, where do you insert the tube? You're going to go probably in the lateral side. So 4th and 5th intercostal space, again, same as a pneumothorax, for example, mid-axillary line, and try to direct the chest tube posteriorly, laterally, or posteriorly. Okay. Now you can go even lower on the chest if you wish. As I said, based on the ultrasound. If you mark where the big pocket of fluid is, you can go really anywhere. The insertion site. This is pretty much to go over anatomy. Thank you to one of our fellows for posing for this picture there. Some former fellows. So. Important to know, different planes, skin, hypodermis. Then, it is important for you to see two things here. Number one, the intercostal vessels. Right. So the intercostal vessels usually run in the inferior border of the rib, internally. Now, they get more exposed, meaning they are not covered by the rib, when they are closer to the spine. So the closer to the spine, the less cover there is, meaning you can actually puncture that vessel, or any of those vessels, and create a bleeding. Now, the farther you are from the spine, meaning the more lateral you are, you're safer, because now the intercostal arteries and veins actually start going under the rib, always in the inferior part of the rib. And then, if you actually go on the lateral place and in the anterior part of the chest, then they're completely covered. So the risk is much, much less. Okay, that's why they came up with this safe triangle that you probably have learned in anatomy or in surgery when you did your rotations as a medical student. This triangle here, or trapezium, is actually shaped by the pectoris major anteriorly, the base of the axilla superiorly. Posteriorly, you'll see the latissimus dorsi, and then in the bottom, the fifth intercostal space. If you go in that region, you are pretty much safe from any vessel. Okay, any vessel, any major structure that can actually run through. Now, again, this is before the era of ultrasound, right? Now with the ultrasound, you can really go anywhere because you are able now to see even the vessels, so you can do a Doppler, for example, of the vessels in the intercostal vessels and find out where to go with your chest. For a pneumothorax, as I mentioned, you can do the first approach there, or also the anterior approach. The anterior approach, second intercostal space with the mid-clavicle or clavicular line. Safe because pneumothorax usually tend to go up. Now, we're not talking about loculated pneumothorax, loculated effusions, or any of that, for which an ultrasound helps. So bottom line, ultrasound helps all the time for the placement of these chest tubes. Now, what types of chest tubes are there? Oh, in general. And I like to classify them due to the type of insertion. I mean, you have 1 million chest tubes in the market right now. And then if you classify them by the type of insertion, then I think you'll have a better understanding of what's going on. So, first, the operative tube thoracostomy, or the operative thoracostomy, also called surgical chest tube, or surgical thoracostomy tube. This is the classic way of placing a chest tube. The surgeons do it. You make an incision, you dissect through the intercostal space, right? Dissect to the Kelly, get all the way into the pleural space, and then insert your chest tube. The classic way of inserting a chest tube. You can put any bore chest tube this way. Okay? The problem is it takes time. You don't necessarily have to follow with ultrasound. That's actually one of the advantages. If you don't have an ultrasound, available at the moment, you can do this approach. But you need many of them to learn. And so it's kind of sometimes for somebody who hasn't done surgery or enough procedures, they may feel uncomfortable just to go through through all these planes to get into the pleural space. That's one type. A second type is inserting the tube with a trocar. There are tubes that come already prepared with these chest tubes that come with a trocar inside. You can have straight chest tubes with a trocar inside. You can have pigtail chest tubes that come with a trocar to insert the tube. Okay, so that's important to know. And what a trocar is pretty much is like a big a metal sharp needle or device that goes inside of the chest tube and allows you to advance and perforate and go through all the planes of the chest wall to get into the pleural space. Again, you have different sizes of chest tubes with this. You can put the big trocars actually very old. You're talking about like a 28 or 32 French chest tubes that were inserted with a trocar. This is many years ago. I only see pictures about it. Now you have a smaller chest tube. You have like a 10, 12, 14 chest tubes that come with a trocar. Actually, is another way of inserting. The other type of insertion is with the use of a guide wire. Very simple. You guys have, most of you probably, or if not all of you, have placed a central line. It's pretty much the same. Right? So, but in this case, you're putting it inside of the pleural space. And this is the one that we're going to practice on the hands-on tomorrow and Friday. So, you actually go with a needle first into the pleural space. You insert the guide wire with the J part into the pleural space. You leave the guide wire, remove the needle, and then go with the dilator, dilate that area, the insertion area, and then go with the chest tube over the guide wire, remove the guide wire, and the chest tube is in. So again, you still can have with a guide wire, you can have with the tip of a pigtail or a straight tip. The straight tips actually can come with this kind of device with a guide wire. And different sizes also. You start from size 8 French to 10, 12, 14, etc. And the fourth type of insertion of a chest tube. This is via thoracostomy with a thoracoscopy guidance. This is what we do actually in the OR. If any of you have been in the OR when we do medical thoracoscopies, this is how we insert a chest tube at the end of the procedure. You pretty much put thoracoscope with a camera at the distal end of the chest tube to guide and go through the insertion of our trocar, remove the trocar before that, and then go into the pleural space and leave the chest tube in there. This is under the direct visualization, so you're seeing how the chest tube is getting into the pleural space. Not something that you guys are going to do in the ICUs, for example, on the floors. So those are the 4 types of insertion of a chest tube. Sizes, different sizes. We can divide them into small bore chest tubes or large bore chest tubes. Small bores usually go up to 14 French, and large goes from 14 and beyond. The small bores, when do we use them? This is already based on the studies done before. Pretty much, when it comes to pneumothorax, you want a small bore. Pleural effusion, you don't need a large bore. A small bore should be okay, up to 14 French. Malignant effusion is the same. Complicated parapneumonic effusions are the same too. And PG is going to talk about this next month. Pleurolysis, the same. So you don't really need a large bore chest tube in order to perform pleurolysis like it was believed in the past. Okay, so the small bore chest tube is enough. Pretty much, if you go with a 14, you hit them all. You're fine. Okay, so 12 or 14 French, you're fine. Okay, and it doesn't matter in terms of the type of tip of a chest tube, either straight or pigtail, they're all the same. Okay, so now you have one of the advantages of a small bore chest tubes is that they will create or they will cause less pain for the patient. The bigger the chest tube is, the more pain the patients will have. So less comfortable. When do you actually use large bore chest tubes? And we're talking about 14 and up. Usually with a 28 French, which are really big, use an empyema. Empyema, as I said, the definition of empyema is pus in the pleural space. I'm not talking about a complicated pleural effusion, okay? So pus. Or a hemothorax, a true hemothorax, not just a bloody effusion. So in those cases, you probably want to deal with a large bore chest tube. Confirmation of position, always do a chest x-ray after placing your chest tube. Okay, very important. Just to be for you guys to be familiar with, this is a straight small bore chest tube. It's in a good position. This is a pigtail, small, and this is a wing pneumothorax, which is the one that we're going to use tomorrow. That actually is 14 French. Now you can tell the different locations and why they were placed. This was probably for a pneumothorax. As you see, this was actually placed for a pleural effusion. So you can tell about the position by a chest X-ray. Always do one to confirm the good position of your chest tube. What complications you have? Well, you can see that on that diagram there. And that goes with malposition, which is the most common complication after you place a chest tube, up to 25% or 26% in trauma patients. And of course, in trauma patients, because they have to be done really quick, really fast, and you may not even have an ultrasound available. So look what happens. The chest tube, number one, can actually doesn't get all the way into the pleural space. Okay, that's important to know. So think about that when you put a chest tube in. If you're not getting any return, that's a possibility. You just let it stuck into the chest wall, somewhere in the chest wall. It can actually go into the lung, and that's also a possibility, laceration or perforation of the lung. It can be located into the fissure, and that's another complication too, because when the lung starts expanding, then the chest tube will get trapped in the fissure, and then your chest tube will not be working anymore. You can go actually through the diaphragm into the liver. So remember that. That's a possibility too. You may have a stutter in the pleural space and you went too low. Maybe this is where your needle was before putting the guide wire. And then you advance the chest tube and let it through the diaphragm. So remember that. Those are potential complications. Think about them when you are putting a chest tube and then everything was fine with your needle, your guide wire, but then once the chest tube was in, you're not getting the needle train. So where are you? In which part of the thorax are you? Remember. Other complications from chest tubes, infection, right? If you don't prepare very well the patient, if you don't prepare very well yourself, right? You can actually cause an infection. It's an external device, it's a foreign device that is actually placed in a sterile place. Organ injury, already talked about that. Pre-expansion pulmonary edema is a little, it goes with how fast you actually drain the fluid. Keep that in mind even when you do a thoracentesis, right? It's not very common complication. Patients usually do develop chest pain at the moment of drainage. You shouldn't go over 2 liters, at least not that fast by using negative pressure bottles or negative pressure in general suction. Hemothorax, if you actually hit one of those arteries or veins, the patients will develop hemothorax. So keep that in mind when the fluid that you're getting initially is just a straw color and then all of a sudden turns into red. Ultrasound guidance. As I said, very important. It was very important when it came in use for thoracentesis. The same thing for chest tubes. Overall, when you are using them to mark your area to place a chest tube due to a pleural effusion. So it helps to localize a large fluid pocket, but it also helps you see the surroundings. You can actually see how distal your long parenchyma is from your chest wall, right? You actually know how far away you're going to be from your diaphragm when you place your chest tube. So those are important measurements that you have to take in consideration before placing your chest tube. Localize the pleural line in patients with pneumothorax, right? Sometimes it's hard to do, as I said. You can use Doppler for intercostal arteries to make sure that there is no actually artery in the place where you are going to put your chest tube. Decreases the risk of organ damage and bleeding, for sure. And as I said before, some studies are already done, retrospective, about the use of patients taking antiplatelet medications. And they're actually safe as long as the operator has the skills to do it. Okay, not a first time or a second time. You're talking about somebody who already has done this multiple times and has experience. Chest tube drainage systems. So what happens? Now you place a chest tube. What are you going to do with it now? You have to connect it to a chest tube drainage system. And this is pretty much what I used to use when I was in medical school not long ago. This, right? And if any of you have actually used this. The 3-bottle system. Right? It's very simple. The chest tube goes to bottle number 1. It's connected to bottle number 1. This is where actually we call the collection bottle or the collection chamber is going to collect any fluid that is in the pleural space. Okay? Point number 1. There's a communication between this bottle and the second bottle. Bottle number 2 pretty much is where you're going to have the water seal or the water seal chamber. It's filled up with fluid, with sterile fluid, right, saline. And there's a meniscus that is going to form here, and for you who watch the video, you'll see. So the goal of this bottle is to keep a negative pressure in the pleural space. The pleural space has a negative pressure that ranges between 5 and 15 centimeters of water, minus 5, minus 15 centimeters of water. It's a negative pressure. In order to keep it, you need this bottle. Okay? So this is the water cell channel. You want to see the meniscus going up and down, depending on varying with the breathing. Okay? Then this bottle is connected to a third bottle. The third bottle is the suction bottle. This is going to get, this is actually going to be connected to the suction system in general. Okay? This is to apply suction in patients who have some sort of air leak or in patients that have air in the pleural space. Right? You want air in the pleural space to apply suction. If there's no air in the pleural space, you may want to think it twice. So don't do it if you don't know. So you need to have air in the pleural space to apply suction. That will help with expanding the lung. So those three bottles now, they came out with the idea to put everything together and sell them for more expensive than this. So this is pretty much what we see all the time here in the hospital. Definitely more sterile than all this than we did it before. So same thing, it's the same concept. You have the collection chamber. So this comes from the patient. The chest tube comes in here, collection chamber, whatever fluid comes from the patient. Then it's actually connected to the water seal. Okay, this is where you see the meniscus moving up and down. And then all the air that will come actually into this other chamber here that is connected with the suction. If there's air, you will see air there. If there's air in the pleural space, you will see the air right there in the water seal chamber. The ones that we have seen most of the time here around the hospital, and I'm showing this just because this is the one that is used in the hospital right now. Okay, if it was another brand, then we use that one. I find actually this one easier to handle compared to the other ones. The other ones, actually, the old ones had the suction regulation chamber. It was actually a column of water, and you needed to put how much water depending on how much suction you wanted, but you will never go from 20 of suction to 10 of suction or 40 of suction. You can go there, you'll have to change the entire Pleural system or chest drainage system. This is the one that we have here, collection chamber, all this, water seal chamber, and this is where you see the meniscus going up and down depending on the pressure, on the negative pressure of the pleural space. It's actually already marked, as you see. This is 0, this is centimeters of water. Everything that is above is negative. That's a negative centimeters of water. So this is 1, 2, 5, 10. So you're in a patient, when this is connected to a patient, to a pleural space, then the variation of the meniscus will go from 5 to 15, usually like this. It will be moving with breathing, right? This is where there's escape of air here that is connected to a suction. This is where you regulate the suction now. So you can put any suction on the wall. I usually put it to the max. It doesn't matter. What regulates the amount of suction that is applied to this device is actually here. Okay? So you go from 10, 15, 20, 40. That's suction in centimeters of water. You want to see here an orange valve, an orange square that will show up there whenever there is suction applied. If there's no suction applied, you don't see anything. You guys have seen the video, Mohammed? I just want to go over just a few things there.
Choosing suction, Dr. Diaz, what's your usual, you depend
I'm going to go over that in a few more minutes. This was actually a video done by Dr. Colette and John. I don't know if you guys know John. You know John. He's a resident here now. He's a Persian fellow. So this is the Pleural system, same as we discussed before. And now what it is pretty much going to go over things, but I want you to see how actually the meniscus move. So let's just put it. Can I advance it or?
Yes.
So see how it divides actually and kind of makes sense with the 3-bottle system. So now you see the meniscus there, how it's actually moving with breathing. Right? Now, the fact that there are bubbles there that's telling me that there is air in the pleural space. So there's escape of air in the pleural space, right? It's not supposed to be air, right? It's not supposed to have air in the pleural space. How do you introduce air there? Well, it could be after placing a chest tube. When you place a chest tube, there's going to be air going in. So initially, on every single system, when you connect a pleural valve to a chest tube, or any chest drainage system to a chest tube, you're going to see air initially. That's okay. But usually goes away within seconds. After those seconds, if you apply suction to actually get the air out. But then after that, you shouldn't have any air. If you continue to have air, so two things. Number one is because there's more air that was introduced inadvertently. I mean, it was not probably the procedure took so long that there's too much air inside the pleural space, or maybe there's a bronchopleural fistula, right? So, or there's a fistula between the lung and the pleural space. So that's important to know. So if you see the bubbles there for a long time, something is going on. You have to ask yourself. You're not supposed to see bubbles for that. How can I go to the next?
Can I go back?
I just want to go to the next.
You want to go back to the lecture?
Yes. Okay. Suction or no suction after you place a chest tube drainage. For patients who have a spontaneous leak, either they have a spontaneous pneumothorax, you need to put the patient on suction. Okay? There are no rules about this. However, as I said, my general rule would be, if you have a patient with air in the pleural space, that's an indication for suction. Anything else can wait. Okay? If you have pleural effusion, yeah, you want to suction that because you pretty much want the pleural effusion to be drained faster. There's no rush to do it. You can always wait and leave it to water still. It's going to drain by itself. However, if you have air in the pleural space, yes, you need to go on suction. How much suction? That's the question. So, the minimum amount of suction necessary, right, to maintain a full expansion of the lung. If you're in an emergency situation that the patient has a pneumothorax, a tension pneumothorax, actually just by decompressing with a needle is enough. You're not putting anything on suction. You put the chest tube after that, and if you want to leave it on water seal, that's fine. Okay? Nothing wrong with that. If you don't know, just leave it on water seal. You don't want to harm it. Okay? Now, what is the problem here? If you have a big fistula between the lung parenchyma and the pleural space, then there's a lot of production of air or air coming from the lung into the pleural space. That's going to cause or create a tension pneumothorax again. So in those cases, you need a suction. How much to suction? We usually start on 10 or 20. I usually don't go more than 20. Surgeons tend to go all the way to minus 40. So minus 10 or minus 20 centimeters of water. But as I said, the least amount of suction that is required, that when I do my chest x-ray after putting my chest tube, the lung is will expand. So I have to go for how the lung looks like on a chest x-ray after I place a chest tube. Right? So what I usually do in a pneumothorax, we put him on suction, we shoot a chest x-ray. The lung is fully re-expanded. I don't need suction anymore. That's it. I put it on water seal. The lung is not re-expanded completely, so maybe I continue with suction. Okay? So keep that in mind. It's the least amount of suction. There is no rule about minus 10 or minus 20. I usually go between minus 10 and minus 20. I like not to go that high. Sometimes you have to when the fistulas are huge, like it's an open lung pretty much, just draining all the air into the pleural space. You'll see that once in a while. So keep that in mind. Expansion of lung, and how do you see the expansion of lung? With the chest x-ray. So wait until the chest x-ray is done.
Dr. Diaz,
Yes.
do you evacuate the air when first placing the pigtail or before you connect the system?
So I do, but it's not necessarily It doesn't necessarily has to happen. And the reason for that is just to make it faster, make it go away faster. If you just leave it on water seal, it eventually will do. If you put it on suction, it's the same thing. So yes, I do it just because it's faster than doing other things. But in general terms, as I said, don't go with that. Just you place your chest tube, connect it to a chest drainage system. If this is for a pneumothorax, put a minimum amount of suction. Shoot your chest X-ray and go from there. If the lung is re-expanded, then your suction, you can turn it off. Remember, the more suction you put on a patient, and the more time the patient remains on suction, the higher the risk to develop a bronchopleural fistula or long parenchymal pleural fistula. An early, a persistent early, pretty much. Okay, so remember that. You don't want the patient to be on suction all the time for 5-7 days if it's not needed. After a pneumothorax, for example, iatrogenic pneumothorax that happened in the bronchoscopy suite after transbronchial biopsy, you guys probably, all of you have seen it. We don't want the patient to be on suction for 5 days. That's not reasonable. You don't do that. Usually, they should not develop an early or a persistent early. So what we do is we place a chest tube. Sometimes we drain it, as Ala mentioned. Sometimes we just put it on the chest drainage system. Put it on water seal or suction. We do a chest X-ray, lung is expanded, then water seal. We don't need suction anymore. The next day we repeat a chest X-ray again. Fine, the chest tube comes out. You don't want a chest tube to be there longer than necessary. You don't want suction to be applied longer than necessary. Fluid drainage, when you're draining fluid for a pleural effusion, a large pleural effusion. Some people go with -10 or -20 centimeters of water just to accelerate and speed up the drainage. Okay, if you have any questions, don't put the patient on the chest on suction. Just put it on water seal. It's still going to drain. It'll take a little longer, but at least you are not risking the patient to develop persistent outcome. And increasing until full expansion of the lung. Remember, if the lung is fully expanded, there's no reason to leave the patient on suction. If you ever see a chest tube placed, the lung is fully expanded, the patient is still on suction, something is wrong. There's no reason to do that. Challenge the patient. Even if the patient now has a persistent leak after a week or two, let's say. Patients have had that before. So challenge the patient. Turn off the suction and see if that actually keeps the lung inflated. Because that's what eventually you're going to need in order to remove the chest tube. Your goal, as I said sometimes in the ICU, is when you put somebody on pressors, is what are you going to do to keep him off pressors immediately? So your job is not to keep on pressors and then walk away. It's that you have to do something in order to take the patients off pressors. The same thing here. You put a chest tube. What are you doing for this patient to remove the chest tube as soon as possible? Okay. You don't want the patient to stay with the chest tube forever. Following thoracic surgery, so the surgeons have different approaches in this. Usually they don't want any suction. They just put on water seal because usually they have already placed patients on suction in the OR, intraoperatively, once they put the chest tube. They apply suction and then they go with water seal. When they get to you guys, it's already on water seal. Criteria for removal. When do you remove it? Pneumothorax, fully expanded lung. Lung is expanded, patient is not on suction, take the chest tube out. You don't need the chest tube anymore. You can go with a clamping technique sometimes if you have a suspicion for a no air leak. What is a clamping technique? What you do is the lung is fully expanded. You have here and there some air coming. You can see in your chamber there, on your air chamber. So there may be a leak, but the lung is fully expanded and the patient is tolerating water seal. So you clamp the chest tube. You just go with a Kelly, clamp it. Wait for 4 hours and repeat a chest tube. Clamping is a technique that is not used all the time. You don't have to use clamping before removing a chest tube. Okay? You don't have to. You just can go from water seal and then straight to removal of the chest tube. Some people just feel more comfortable about clamping just because it gives you like more certainty that the patient will do well after to remove the chest tube. Doesn't necessarily happen. So it's questionable. In diffusion, when the lung is expanded. Again, if you have a fully expanded lung after an effusion, you put a chest tube, you have to, and the fluid output is between 100 and 300 milliliters per day, then you probably are safe to remove the chest tube. Let's talk about a little bit about inguinal pleural catheters. We're going to talk about more of this during the workshop. IPC catheters are usually soft metal of silicone, and the lumen, actually not the lumen, but the size of these kind of chest tubes, because these are actually another type of chest tube, is 15.5 French. Only to be used in recurrent effusions. Very important. This is not for somebody who has a pleural effusion for the first time or comes back after a year with another pleural is recurrent. You don't think about this kind of catheters, because the only reason to place these kind of catheters is to relieve dyspnea. That's all. That's its use. There's no other use. Now, you've seen in patients with malignant effusions that up to 40% of them will develop a spontaneous pleurodesis. So you leave the catheter there, all the friction of the catheter against the pleural space, against the pleural membranes, actually, will create this fibrotic tissue inside that will not allow the fluid to build up again, and then hence will create a spontaneous pleurodesis. It can seen up to 40% of the times in patients with malignant effusions. But the main reason why you put this is in a recurrent effusion, that just for dyspnea palliation. That's all. Okay. Now, some studies with low number of subjects actually have been done in benign effusions, CHF. Again, it's the same thing for palliation. You have a patient who you cannot give any more diuretics because it's already, the creatinine is like 7. You cannot do anything else. And it's old, cannot tolerate any pleurodesis. So maybe thinking about putting a pleurodesis catheter at that time is on a case-by-case evaluation. This is what the catheter looks like on the left side. This is, as I said, it's a silicone. It has a cuff. Polyethylene cuff. This is the fenestrated part that goes inside of the pleural space. This is the proximal part with a one-way valve, meaning that nothing is going to come out of here unless you access the valve, not with a syringe, with a needle, but with a special device that connects. This is the cuff. This cuff will go under the skin, in the tunnel part of the catheter. That would actually create formation of fibrotic tissue around, and granulation tissue, which will keep the catheter in place and will not allow for the catheter to move. And on your right-hand side, you'll see that's the drainage system. Patients go home with these kind of catheters, and they actually use bottles that are delivered to their home, and they use it for drainage, to access the catheter and drain anytime they feel short of breath. This is how catheter looks into a patient. And this is the part of things. How do you place it? Put the patient in position, either in 45-degree angle, like you place a chest tube with the arm rotated and in abduction behind the head, or on a lateral decubitus. Okay, whatever it feels more appropriate for the patient has to be comfortable, and you have the ultrasound to decide where to go. Remember that. You clean the patient, you apply lidocaine to 2 places. You apply lidocaine to the insertion site, and you apply lidocaine 5 centimeters approximately more anterior and inferior to the area where you're going to place your catheter. That's going to be the site where the catheter will come out from the patient. So 3 sites that you actually apply lidocaine. 1 in the insertion site, 1 that's 5 centimeters anterior and inferior, and the other one is in the tunnel tract. So the communication between those 2 areas, those 2 sites. Once you get fluid return, okay, this is exactly similar to a central catheter, a central venous catheter. Once you get return, then you leave the guide wire introducer, which is this white part. It's an introducer that goes over the needle. So once you get return, you leave the guide wire introducer and remove the needle. Now, I don't use the guide wire introducer if you guys have done those with me, just because that kings very easily. So I just use the needle and feed the guide wire through the needle. So they're feeding right now the guide wire through the introducer into the pleural space. After the guide wire is in place, then they remove the introducer and they actually make an incision at that side. That's the insertion side. 1 centimeter incision, and you make an incision again 5 centimeters anterior and inferior to that area. So 2 incisions. You prepare the pleurix, the indwelling catheter. There is a tunnelizer. This tunnelizer is made out of metal. Okay, it's a little bit on the tip is slightly sharp, not that much. But that's once you attach the catheter to that tunnelizer, then you put that tunnelizer from the more anterior incision, not where the guide wire is, but the more anterior incision, and you go under the skin, creating the tunnel. It's like you're sewing there. Once you pass it, you can see, right? So you pass the tunnelizer and the catheter is going to pass through it also. Now you have the catheter going through the tunnel all the way. And this is the guide wire. Okay? You remove the tunnelizer, and then what you're going to do is you need to make that hole through the chest wall bigger. So you're going to use a dilator through the guide wire. So you use a smaller dilator. The kit comes with 2 dilators. So you go with one, which is an 8 French. The second is a 12 French. And the third dilator, which is actually comes already with the a sheath that's covering, which is this. So the dilator is the white part that is inside, and this green part with the gray part is the sheath. Okay, so it's an introducer sheath, and you're going to see why we do that. After that, after you're inside, then you remove the dilator together with the guide wire, and only the sheath remains. So at this time, you're going to remove the guide wire with this part. It's no longer there, right? With the dilator. The sheath is actually there now. Oh. And then you put through the sheath the fenestrated part of the pleurix catheter, or the catheter. Then all you have to do is just break the proximal part of the sheath and then peel it away. That's being done there. That's how you remove the catheter. And then you just put dressings. Complications. Bleeding goes up to 2%. It's not that common, but yes, it could happen overall when you don't pay attention to the ultrasound and to the place that you're placing, or to the area that you're placing the catheter. Malposition, sometimes the catheters actually go all the way up to the apex. It's hard sometimes when you have a patient with a large effusion to actually keep it in place. However, if it's a free-flowing effusion, the catheter just by gravity will just go down. So not really a big deal. Malfunctioning. These catheters can actually clog. And if they clog, then you need to open them again. Or if not, if that doesn't work, sometimes installation of TPA, installation of saline, if it doesn't work, then you have to remove the catheter. Tumor overgrowth has been seen because this is placed mainly in malignant effusions. So the tract gets seeded with tumor cells, and then you start seeing the cancer advancing on the skin. Never seen that before. I've seen the pictures. Infection can go up to 5%. If it's an infected catheter, you remove it. Unsuccessful insertion, again, think about what the chest tube is. Maybe you actually went into the chest wall rather than the pleural space. So keep that in mind. And pain, up to 5%. You always have to give patients some degree of pain medications for this. The management is home drainage. As I said, you do this so the patient can be discharged from the hospital. You don't want the patient to be here with a Pleural catheter. They go home, and the patient is set up for a nurse or a family member can actually drain it. It's very easy. It's very simple. How often? Is as often as needed to palliate the symptoms. 3 times per week, the average. There are actually other institutions, they do it initially, daily, and they have seen that actually accelerates pleurodesis in these patients. But still, this is off records, and the research, nothing has been done for that yet. When do you remove it? When you actually encounter 50 milliliters or less of drainage 3 times in a row. So if that happens, it's either because the catheter is clogged or it's because you achieve pleurodesis. Of course, that has to trigger a chest X-ray before you remove it. And then if it's clogged, then maybe try TPA, try saline. If it doesn't work, you have to take it out. If there's an infection and obstruction that you cannot relieve, then probably you have to take it out. Any questions? Yes?
The indication for the Hemothorax catheter, shouldn't the lung re-expand after you drain the fluid?
Well, it depends why you put it. So one of the indications is, as I said, usually is malignant effusions. But malignant effusions or malignant pleural space with a trapped lung, they will never re-expand.
But you still put these two.
Right, because the indication is to relieve this. And in patients who actually have trapped lung, that you have proof that doing a thoracentesis or draining fluid relieves dyspnea, and you know it's going to come back,
For this.
then you put this. So you don't necessarily wait until the lung re-expands, because if you have a trapped lung, it's never going to re-expand.
Yeah, if these trapped lung patients go home with the Pleurex and they're doing home drainage, how do they kind of regulate against that of pneumothorax? Because they'll probably just keep draining.
By pain. So you have to tell them to drain it slow, because they're going to develop pain when the lung is not able to re-expand, and you create too much negative pressure in the pleural space. So you tell them, go slow, and then kind of mark how much fluid you're draining. So if they say, after 200 mLs I start having pain, okay, stop your drainage right there. You should not continue. And the pain is probably because it's a trapped lung, creating negative pressure, is not re-expanding pain. So by pain, unfortunately, they cannot check the pressures there, which would be ideal, but it's not possible. Yes.
What is your experience of when you take out a chest tube for pleural effusions? I know some surgeons do like 150, under 150, some are 200.
The average, the ones that I usually go with 150 a month. Yeah. Now it varies too. You need to think ahead and say, okay, what's the next step? Okay, so why did I place a chest tube in the first place? Just to drain it fast, to achieve what? Right? So, is this somebody that I actually need to take for a thoracoscopy, maybe a pleurodesis? Right? So maybe I need to do that. So, it's not about you find a pleural effusion and you say, okay, let's put a chest tube because it's a large pleural effusion. But then after that, what? So even if it's 300, and I know this is all malignant, I'm probably going to take the patient for a pleurodesis. Because I'm not going to allow the patient to stay there in the hospital with the chest tube hanging for 10 or 20 days until the drainage is less than 300. It's not going to happen. So I need to act and do something else. Because I don't want that, as I said, what am I going to do for the chest tube to come out? I don't want the chest tube to be there a long time.
Would you put a pleurodesis on the first time infusion that was large, that it was draining for a while? Or would you wait?
No, first of all, what are the indications for pleurodesis? We went over this back in March when I did it. So, if it's a malignant pleural effusion with the signs that it's going to recur and the patient doesn't have any other treatment available, probably you need to think about pleurodesis. If you think about just a heart failure patient that is recurrent again, you probably need a valvular reason. But if not, this is the first time ever infusion that you still don't know what's going on. You need more information. So what do I do in those cases? I drain the fluid. Okay, maybe the patient needs to go for a thoracoscopy for biopsies and find out exactly why he's producing so much fluid. Right? So biopsies of the pleural. So everything is kind of coordinated and think about it. It's not just about placing a chest tube and that's it. So you need to know why you're placing the chest tube and what's the plan of the patient down the road.
Main elevator, main hallway,
Any other questions?
main elevator, main hallway.
No? Okay. Did everybody turn in the
The evaluation